Okay, so here we are, live again. Last time of the day. Has been a powerful day. My head is still about how amazing people we have, and how much information and how many things in common we got, and that's the beauty about this. We have a special friend as a guest. I know Konstantin Ronkinn for, my God, I pretty much from the beginning that I started taking classes in neuromuscular dentistry. And he's been one of the leaders worldwide about the concepts of neuromuscular dentistry. And as a fact, he's the president, and he was the one that opens an institute, ICMO, in Russia. So it's really important. He's going to tell us little bit about the ICMO group, and where we start and how many locations we have worldwide. Because I think now that we're talking about how many things we have in common, I can tell you that is more things in common that we have different. And in ICMO is a good source of information for many of these holistic things and these holistic approaches that we've been touching base in these 21 interviews that we have. So it's a pleasure to have it. Let me pass it to Hamid, but also Hamid, we've been friends forever with Konstantin.
That's correct. That's correct. So it's great to have everybody along with us. We have a special guest today, not only a good friend, but a great clinician that's well known both on the East and the West, and with his both centers in Russia and another one in Boston. He has a lot of clout going around. Luckily for us, we've got to know him through our trainings and our interactions in ICMO. And he brings a very special perspective from both sides. I know from previous and from past experiences in my classmates, always my Russian classmates had very strong science backgrounds and very strong in basic knowledge. And it was very interesting to have one of them on the board with us. So without further ado, welcome, Konstantin.
Thank you, guys. So hello from Boston. So it's already evening, and now neck of the woods.
But it's a beautiful day over there. Look at that.
Yeah. So it's like sunny now, and not like yesterday. But since we are going to talk about occlusion and everything what connects to this. Oops, I lost you guys for a second.
I can't hear you. So yeah. Let's start before. Yeah, go ahead.
So I just want to go to the clinical side. So, and since you mentioned ICMO, I have this ICMO logo, and just you wanted me to say something about ICMO a little bit?
Yeah, let's say the people. We have some members that they speak already.
Maybe not everybody knows what is ICMO means. It's the International College of Craniomandibular Orthopedics, and it's a great organization. Doctors all over the world doing some research, and we teach dentists on the subject of neuromuscular and physiologic dentistry. And we opened our section in Russia in 2013. And since that time, we have several masters and over like more than 10 fellows of this organization. It means that they went through extensive training, and they did the cases and defended these cases. So it's pretty knowledgeable guys.
So how many sessions we have around the world? So people that is seeing worldwide can go and look for ICMO. Where we have this ICMO located worldwide?
So it's all together, I believe it's 14 countries right now. And I don't know how many members. I know how many members in Russia, but I don't know how many members worldwide. But it's great organization because we all like friends, and it doesn't matter that we think a little bit different, but what is most important, we think physiological way, and we think about treating not just TMD problems or malocclusion or sleep apnea or other stuff. We're thinking about to treat patients with all these problems, not just separate problems. This is a approach what we taking at ICMA.
That's beautiful. And ICMO was created by Dr. Bernal Jankeson. How many years ago? We have the anniversary 35 years ago, I think.
Yeah, I believe more, but yeah.
Anyway, so that's beautiful. So anyways, we also want two guys to invite you. Hamir and I mean, personally, I've been part of the organization for almost 16 years. And it's too many different perspectives over there. A lot of physiological ideas, everything that we've been talking for posture, airway, occlusion alternatives for orthodontics, for prosthodontics. It's a whole material, only thinking in a physiological way. Of course, we welcome to all these people with different thinking, because we find out that we have too many things in common. So how do you get involved with this amazing world of physiological occlusion? Or how was you at the beginning?
I believe it started at LVI for me, and then I was introduced to ICMA and continue my training through ICMA, through people what involved in ICMA. I can mention Dr. Garber. I took a lot of courses of his, Rokabada, when we probably did together. I remember you helped him, and a lot of other people. Chen also.
Dr. Chen.
I got a lot of knowledge from him. So it's a lot of people, and we still continue learning. It's like endless process.
Absolutely, you're absolutely.
I think the safest state of life is to still a student, because that cover us in the way that we keep going with evolution of concepts, right? So, Konstantin, for how many years do you do in neuromuscular dentistry or physiological occlusion now?
More than 20.
Are you seeing changes, like we keep principles, but you notice changes in modalities or adopting things?
Maybe a better question: how have you evolved in your thought process from the beginning to now? How are you different when you look back retrospectively on what you were doing at the beginning versus now? How do you see it different? I know we are. You
don't even need to think too far back. Let me tell you, whatever I did a year ago, I'm probably not doing right now, or I'm doing a little bit differently now than even a year ago. And let me tell you, we have a institute. We call this Boston Institute of Aesthetic Dentistry in Russia, and we're doing some research. And every 5 years, approximately, we're doing certain research and see how successful we are in the treatment of our TMD patients and sleep apnea patients. And I see every time when we introduce something new, our success rate is higher and higher. And right now it's approximately 87%. If we're talking about 5 and 10 years after the treatment, we calculate how stable the occlusion and how stable the patient. So it's 87%. And for example, we didn't think about cranium too much. Even like 5 years ago, we assumed that everything fine with the patient, that his upper jaw leveled, that sphenoid bone leveled, and temporalis, temporal bone leveled. But in reality, as you know, it's not. And as soon as we start to take a look and correct the position of these cranial bones, our success rate in the treatment of these patients become more and more and more. So this is how, like, it's like changing, we change the procedure almost, I don't know, every month, let's say.
So you start working with craniodontics or osteopaths doing cranial release techniques? That's what you've been implementing?
Yeah, basically we have a osteopath. I have osteopath. You know, in Russia I have osteopaths. Here in the United States we have new chiropractors. So this is a difference. But you see, this is my office, like dental office behind me, and this little door, what you see, this is a door to my osteopath office. So it's basically 2 meters between my chair and her chair, which is a
That
6
is awesome.
Yeah,
it's
so
a completely integrated office you have.
Yeah, absolutely. And I believe this is a only way, but this is ideal thing. In reality, we know not everybody can have this setup, and I don't have the same setup in Boston. But like we had a discussion with Javier like a minute ago. If you understand the principles, the physiological principles, so you're going to do everything according to these principles, even if you don't have some ideal situation.
Yeah, we will get to that question because I was asking Konstantin what he think about if we have to do this procedure like Francesca tell us, if we're in the desert and we have desert, and we don't have nothing of the instruments that we normally work. The question is, can you guys able to do what you do? So that was the question that I'm insinuating.
Yes. But that's Javier. So you don't need to go to desert. For example, if you have a patient with a pacemaker, right, and you can use the TENS unit, what you usually probably use, right? But still, you can do without TENS, but you understand the principles, the physiology, and you're going to make less mistakes if you understand this than if you don't know any physiology. And I always saying, let me make these mistakes to the patients, then somebody else gonna do this without this physiological knowledge.
Of course, yeah. Yeah, equipment doesn't treat the patient, right? Equipment's still a human behind to interpret the data. Mostly the biometric equipment that we use is still a lot of analytics today. Yeah. So
verification tool.
I always telling my students that you can use any equipment or no equipment at all, and to establish the right occlusion, as long as somehow you check physiology. That's it. You can use a manipulation of the lower jaw, you can use a Slavichik, you can use a Kois, you can use any concept, any occlusal concept you would like, but please check physiology, check the breathing, check the muscles, and you're going to be fine.
Yeah, that's the beauty. That's why we have a common denominator with all the different expressions of occlusion that we've been having here over these 21 interviews. we were talking about it and say why the rate of success is too high. And then we've been focused in this meeting to find out what we have in common. And then I think the analogy is, I think what we have in common is make that every philosophy, even with variables of the modalities that I take in the bite, since people is having the same physiological thinking or their awareness, everything is going successful. So it's something that is giving us something good, because maybe we've been arguing many years for what we have different, and then we never get in love with what we really have in common. That I think this quarantine need to do something in our brains or our minds.
Correct. There's got to be something positive
Yeah,
should come out of this quarantine.
definitely.
So yeah, absolutely. I think you're right on the money there, Konstantin, that as long as we're moving based on physiologic principle, it doesn't matter whether you're just an astute clinician and you can kind of see it. Because I've seen that some of these guys with their lecture, and their work is just beautiful and impeccable, and their patients are feeling much better. So it's not about the machinery, really. It's about that astute clinician who really can, in their mind's eye, imagine what's happening, in the dynamics of that joint, and whether this is a clean trajectory and the stuff that we're looking for. But maybe we're documenting really with the machine. But the reality is that, you mentioned Dr. Chan. He always said, don't be a computer watcher. Look at your patient. Look at your patient,
Absolutely, yeah.
So that goes through the same thought process. And it's great to know that the ICMO is open to all these thought processes. And we would love to have some of these guys someday presenting at ICMO, possibly.
Yes, definitely. Konstantin, in these 20 years that you've been doing neuromuscular dentistry, I know for sure the answer, because in ICMO is too many great people that they've been doing this forever. I mean, we have people like Barry Cooper that he started doing this with Robert Jankelson, so he's technically doing this for 50 years. And I personally remember that I hired him 15 years ago, just a one-to-one teaching session for me in 2 days that we did in his house. And he went over hundreds of cases, showing me scan interpretation, how was his thinking process. And then what I started finding is, even though we have the same principles, we use same instrumentation, we all have still different modalities or techniques that we implement during the taking of the records, and sometimes during the time that we take in that bite. And I know that you've been aware, because you've been also one of these looking researchers that you're looking at, okay, let me see how this doing, how this doing, how this doing. And then you start teaching like something else, right? Because when we committed to teaching, we have to see it for different angles. And then we will find out how can be the easiest ways that it works in our hands to teach the students. So how you can tell us a little bit about those different modalities? What do you think has been building up or adding up into the standard neuromuscular procedure? What we pay attention more, or what modalities we doing as an to take a better bite registration, or a better first bite registration? Let's put it that way.
All right. So can we kind of step back a little bit and start what we kind of understand what is occlusion for us? Because so many people you already interviewed, and it's a little bit different, understanding what is occlusion. What for us, occlusion starts with I already mentioned, with the position of the upper jaw, and it's not just teeth; it's just jaw itself, and this jaw connected to other cranial bones I already mentioned. The second part of this is the posture, because it's very important where the head gonna be. The head's supposed to be in the right place to determine, to register right physiological position of the lower jaw, and occlusion is a final product. So, and if we're talking about posture, we're starting with the legs and hips, and it will go up and up to the neck, and especially first and second vertebra. It's very important for us. And then we're talking about airway. Airway, it will airway determine the occlusion, and occlusion also determine airway. And then we're talking about a position of the lower jaw, and then we're talking about the joint itself. And as a final is like micro-occlusion. And when we're talking about micro-occlusion, we're looking for the angle classification, we're looking for the plane of Wilson and Spey, and we're talking about no interferences, etc., etc. We're talking about guidance and canine guidance, anterior guidance. So all these principles, right?
Natological landmarks included.
Absolutely. But this is not the end of the story, because now we need to take in consideration the whole body and the health of the whole body. And that's why we checking for every single patient who is coming to us. We're checking pH of the body. We're checking we're doing some other tests to understand the balance of the body, because what we try to do, we try to gain the balance, right? When we establish the right physiological occlusion, we would like to establish the balance. But if for example, patients have a hyperthyroidism, right? The lower hormones of thyroid gland, it's not the balance, and it will affect our treatment for like TMD treatment or occlusion treatment. So we take in consideration the health of the whole body. That's why in Moscow, we build a huge center, and we have a cardiologist, endocrinologist, ENT doctor, etc. We have like multiple disciplinary facility, and it's a lot of people involved. But and when we're talking about all these complex of problems what patient could have, and we straight these problems, then we can tell, okay, we establish the physiological occlusion. Now, let's assume, like you mentioned, how we register the final position of the lower jaw. So let's assume that we corrected the position of the upper jaw, and we corrected the position of the head by kind of correcting the posture of the patient. So, and like I mentioned, it's only like 6 feet between the osteopath chair and my chair. And then if I see that all this, the upper jaw in the right place, neck in the right place, head in the right place, then I will use TENS and my equipment to establish the physiological position of the lower jaw, stabilize this position, and then treat the patient in this position. This is what physiological occlusion means for us.
Beautiful, perfect explanation.
That's great.
Okay, so let's talk about that first bite registration. You mentioned that you have the work together with the osteopath, and then you have a workflow. Of course, that workflow work different when you in the States than when you in Russia. And how can be that transition into the process? Let's say that a patient is coming, and the first part that you make is your clinical history, your analysis, you realize postural issues, and also you make your entire exam, and you realize also there was an occlusal disharmony. What can be that setup that you will say, okay, based on my experience, I'm going to put the patient first with the osteopath first, or I'm going to start breaking the ingrams between the teeth. Let me throw something between the teeth, so I start deprogramming the patient. What is your workflow into that time prior to you take the bite? Because, or correct me if I'm wrong, is the first bite the last bite that you take, or is different bites that has been taken under the principle to letting the body to express?
All right. So first of all, the probably 90% of the patient what I see in Russia is TMD patients. So this is what I'm doing there. So in Boston, it's a little bit different. We see all kind of patients. We're doing general dentistry as well. So if I see TMD patients and the patient coming to me with symptoms, first of all, I assume that the patient has a sleep apnea. According to the literature, you know that approximately 80% of patients with TMD symptoms have a sleep apnea. So that's why until I prove opposite, I assume that the patient has a sleep apnea issue.
Konstantin, I'm sorry. Is that sleep apnea or sleep breathing disorders? Because
sleep breathing disorders, but you know that among
not
the sleep,
necessarily apneic, correct?
Yeah, among the sleep breathing disorders, the most disorders it's apnea, especially what we're dealing with, right?
I see.
So, and this is number one in this flow. I send patient to have a PhD done and evaluate by somnologist or sleep doctor and exclude the sleep apnea or confirm this diagnosis.
But this is all happening in your diagnostic phase before you start even considering to do anything.
Absolutely. Now, when you see the patient, you can evaluate and you can see if patient has certain postural problems. And if it does, so I'm sending patient to a chiropractor or osteopath before I'm taking the bite registration, because it's going to happen on a second or third visit. Okay. Also, in our clinic, the CT scan is a standard procedure for all patients. It's not the FMX, it's not a panoramic X-ray, it's a CAT scan, right? So, and when we're doing this, we have a pretty much good idea what's going on with development of the midface, what's going on with airway, and position of the jaw. And of course, we going through the very detailed questionnaire and determine what bother patient, because you know the patient's not going to come to us because of headaches or some other issues. They coming to us because they have some problems with the teeth, right? So that's why you have to go through this very detailed evaluation of symptoms and signs of TMD or sleep apnea or other issues.
So in the sequence of treatment of the patient, of this dysfunctional patient, most likely all the patients, they have too many things in common, right? We start seeing breakage of the teeth, we see triangular arches, narrow arches, crowding, premolars drop off, many things that we have into the signs and symptoms, right? And that kind of tells us that it still is no harmony in general for the occlusion. And then so you guys take a bite, and the bite is going to be like the first bite to stabilize the system, but it's still components that are not resolved. Like a patient that is still having crowding, is going to be difficult that patient has a space and normally a round arch to have the tongue very below. So that create abnormal swallowing patterns. So with the first orthotic that you guys put it, basically you're stabilizing part of the system, but it's still more to go if we want to go to really achieve specific goals, because it's many factors involved. How is your communication, or how is that transition between this patient that is coming for phase one, that is still, we call phase one diagnostic until we stabilize patients, but in many cases that they cannot be totally stable because it's factors that they're against to the proper resolution. Patient that really constricted, no matter where you put that bite, there's still no space for the tongue. And of course, it's a strategies which can be more vertical dimensions for temporally gain a little more tongue space. But those cases require an interdisciplinary phase into the first phase eventually. How do you control that part? Are you doing everything in-house, the part of the orthodontics? And how you working with these intermediate phases of the treatments?
So answering your question about, is it final bite? My first bite is final or not? Of course not. Sometimes I have to redo orthotic. For example, I put orthosis in and muscles start to recover, and the patient going through the osteopathic treatment. And this, after every single visit to osteopath, I have to readjust the occlusion. Sometimes it's impossible to do adjustment by just adjusting the orthotic. I have to do new one. So this is number one. Number two, I try to establish the position of the lower jaw. And the class 2 division 2, when the teeth like this, and they holding the jaw in this locked position. And for example, if this position after tense is too much forward and these teeth not letting lower jaw goes forward, then I have to step back, do some orthodontia, and we're doing everything in the house. I'm doing all ortho. And sometimes it's just simple Invisalign or simple braces. So just move these front teeth away from the position of the lower jaw. So I have to redo my K7 and establish new position of the lower jaw. Or let me give you another example. You do the your K7 and you find the beautiful position of the lower jaw, muscles perfect. You confirm with the X-ray. You see the position of the condyles in the right place. Everything perfect, airway perfect, and you ready to go to the second phase. But you see the face aesthetics, and you realize that you created class 3 phase, right? But it's not class 3. It's not like because of lower jaw, because you have an undeveloped upper jaw. So again, you have to step back and develop the upper jaw, and we know exactly how much it needs to go forward. And you're doing FAGA, RAGA, DNA, ILF, whatever technique you're using, you're developing the upper jaw. And very often, especially if you establish good airway, if you establish good position of the tongue and good function of the tongue, and if the lip sealed, lower jaw will follow upper jaw when you develop upper jaw forward. And very often I'm doing the K7 after this, and I see, so my lower jaw on the trajectory, on the physiological trajectory, you don't need to do anything. But if it's not, then you do a little bit of neuromuscular treatment, you establish new position of the lower jaw, new occlusion, everything.
You can say that we can use the initial bites as a diagnostic tool to understand skeletic discrepancies. Absolutely. More than just muscles unbalance, because that's part of
absolutely. Sometimes I'm having patients to do the K7 evaluation and determine the bite, and I can't determine the bite. I just do evaluation and realize that I have to do something else first, and I'm doing this first, and then do the K7 again, and then establish the position of the occlusion.
We're getting close to 6:37.
Yeah, last question, Hamid, before you jump into the question.
Yeah. Konstantin, can you tell me about let's say a case that you get with a lot of adhesion, a lot of derangement in the jaw joint, and it's just impossible to get that. What do you normally do with those cases? How do you get those started?
If it depends, if it's patient symptomatic, so we have to get out of pain patients. But basically, we determine the position of the condyles and position of the lower jaw by using TENS unit, right? And the TENS will move the jaw to the position comfortable for the muscles. And very often when we confirm this with X-ray, we see the condyle in a good position as well.
No, but we were talking is because we were talking about adhesions inside the joint. So last night we have a maxillofacial surgeon that he was sharing experience about 500 surgeries that he has done, and he's doing more conservative now. But the point is that he's seen that adhesions are the hiding enemy, because sometimes we don't see it, we cannot diagnose it. We just seen that we don't have the proper range of motion. And most of the time, the patients are asymptomatic. And many times, this can be confused with another joint derangement. And then we underestimating the power of an adhesion that is technically not going to let us that condyle to move equal to the other one. And then when we use TENS, that can shift the mandibular path of trajectory, because we have a mechanical adhesions here that is blocking us to get that. So we've been talking about different techniques, and of course surgically, arthrocentesis, and then also some manual therapies. For instance, that's what I did in my wife's case. But still is adhesions that is still there. So we just want to see what can be your input in those cases that you eventually can.
Yeah, because sometimes in some cases we've seen that we've gotten kind of like a false positive, or falsely thinking that the TENS is going to correct that, and you see the patients, pulsing in an angled way.
But in any case, this is our approach, and we're doing some surgical cases as well, because I have oral surgeon. Okay, it's another door. So, but I agree that we have to decompress the joint anyway. So and this the occlusion was what we established for this type of patients, not the final occlusion. It's not the occlusion to do even phase 1. It's just decompress the joint, and then we send a patient to oral surgeon, and he can do whatever procedure he prefer to do. And but joint going to be already decompressed, and so this is how we treating these patients. And
perfect.
Konstantin, I'm really in love with that lecture that you shared with me about these maxillofacial cases, research that you did in Moscow, remember?
Yeah.
I really will love that if you have the opportunity on Friday to make your presentation, you will show some of that, because we have a nice group of maxillofacial surgeons that they follow us. And I'm here in the States. I'm part of a group of Dr. Arnett in Santa Barbara, and it's beautiful. I mean, try to reproduce something like you did in that study. So I will be talking about.
I have no problem. Yeah, so you're talking about these patients with
tumors
after surgery, after remove the half of the face. Yeah.
So can you tell us a little bit about that, so we start preparing the people about that? What is your creativity? Because again, this is like when we have the research hearts that we start trying the impossible, right? And I want that, honestly, I was so excited when I saw that research that you did with these cases, that you say, how the hell this patient is going to function? He's not condyle at all. How is the dynamics? And then you record this with kinesiograph equipment. Tell us a little about that experience. I find it fascinating for myself.
So my surgeon who is working in our office, he's doing a lot of reconstructive surgery after after some tumor process or trauma. And the question was, the first question what we would like to answer, if muscles reattach to these grafts. This is number one. And we prove they reattach and they start to function. That's why we use this electromyography. And the other question was how to establish the position of the jaw, how to determine the bite for this type of patients, because we don't have a condyle in a socket, right? So that's what was purpose for this study. So I can share this study with you.
So
Yeah,
that is part of what we're gonna see on Friday. It's a weird, crazy, beautiful things to see. And then, honestly, when you see all this is when you start realizing, okay, we have physiology of the human body is fascinating. It's just how the body find a way to make the function. And in that way is what create what people call compensation. But it's beautiful. It's no other way the body to repair by itself. So beautiful, Konstantin. You've been awesome. Now you need to pass the exam. Yeah. I'm kidding. Yeah, now the formal question.
All right, Konstantin. I think you answered this very eloquently before. Can you do it again? What is occlusion to you, and who were your influencers?
Again, I lost you. All right. So I already kind of answered this question, what the occlusion for me. And we have a kind of definition. We call this optimal physiological occlusion. And first of all, it's important for us what happened before teeth touched together and after. So first of all, the muscle's supposed to be comfortable. The second, the joint needs to be, the head of the joint supposed to be in the right position, and disc supposed to be in the right position. So it's like ideal scene. And airway and breathing needs to be established and needs to be normalized. Posture needs to be normalized, and the whole balance of the body. And if we create this, it will stabilize the result. It doesn't matter what you're doing the ortho treatment or prosto treatment. So if you would like to, these restorations, what you put in the mouth, serve for a long time for the patient. So that's what you need to create: balanced physiological occlusion with all these components in place.
Okay, this answer give me a little bit of another question that we have to ask. So are you having the patients when an orthotic for the day, and then you have an appliance for the sleep apnea at night? How you work in this combination? Is your position of the day the position for your sleep appliance? So what is your thinking process? Peter Ferro kind of tell us his idea in the way that he's working. How about you?
Basically you're asking how I treat the patients with the sleep apnea and TMD problems, right?
Yes.
Together. So basically, again, if the patient's symptomatic, we need to take the patient out of pain and symptoms. But if patient has a severe sleep apnea, you don't have a time to do this. So you have to put the patient on a CPAP and during this treatment, and then relocate the jaw, develop the upper jaw, try to widen his arch. And then after this first phase of the treatment, you see if the AHI better to the point that you can get a patient off CPAP, then you doing your sleep appliance, but you already finished the first phase, and you can finish the second phase. And after second phase, after you finish second phase, you don't need to wear any orthosis during the day. You just wear the sleep appliance.
Okay. Yeah,
That's
because
it.
Peter was telling you, yeah, that his position is pretty much similar, a little more space, some consideration, but he always say that in his protocol, he take two by registration, one that the one that he's gonna use an orthotic, and he will use the other one for an sleep lab
Yeah.
appliance and
Same
okay.
same philosophy. But one more thing, if I may. Right now, we're using this technology, DNA, Vivos technology, whatever you call this. We try to cure sleep apnea before we do in second phase. This is a kind of new, and I have approximately like 30, 40 patients going through the treatment right now. So after I'm done, I will tell you the
We're
result.
talking about DNA appliance.
Yeah, DNA, mRNA appliances.
Okay, so for those that they don't know around there, and maybe you guys can connect a little bit of what we're talking this morning early about orthopedic appliances, but in the morning we were talking about kits. It's a similar concept. It's a concept based in orthopedics, based in the concept of no forces, just touching. That is the concept of presence, as Patricia mentioned this morning. So it's a similar concept. Appliances with a little mild pressure, little tension, with a little micro springs that they susceptible for the tongue movement and create some sort of activation that develop new osteoblastos to come in and try to create a new opposition growth around the developing of the structure. This is just a foundation. Of course, DNA is a trademark appliance, but basically is based in the principles of the orthopedics. Am I correct?
Yeah, yeah.
Okay, good.
All right, let's go to question number 3, which was the actually question number 2, but you already somewhat touched on it, which is the factors that you consider prior to stabilization, and those were basically everything you mentioned: posture, sleep, airway, what else? Joint position, and so on and so forth.
Yeah. The most important for us, the most important is physiology for us. So even if I see that everything looks beautiful and according to some guidelines, but if the physiology not there, if for example patient doesn't breathe, so it's not the optimal occlusion. So we need to do something about this. So we're checking 2 things if we're talking about physiology. It's muscle tone and airway, the breathing. So PSG.
Konstantin, this is another question. And I think, Hamid, I apologize, I'm taking some extra time. But I think it's important to people they always ask questions about part of this physiology about the neuromuscular occlusion. So let me ask you something. Do you ever found a case that eventually patient doesn't want to do restorative treatment or ortho treatment, and then what you find out is that the patient, the bite, of course, is behind that where you expected? Is any way, having as a consideration neuromuscular principles, that you can still use the tensing and the muscle relaxation and can to let that mandible to set up a little behind or where the tense is doing it, just because let's say that the patient say, doctor, what you can do, I don't want to have ortho, I don't want to have restorative treatment. Is any way to establish a neuromuscular position that doesn't go all the way with the envelope of muscle relaxation induced by the tense? Is any possibility to try to be a little more conservative into the movement, taking advantage of the muscle relaxation, the torquing, about the pulsation of the tense, but trying to control a little bit that propelling of the mandible to go forward?
Yeah, you're right. So we have 2 solutions. Number 1, if the patient can go to the second phase, doesn't matter if restorative or ortho or surgery, right? But patient willing to wear the orthosis, then we can do beautiful mild type of orthotic, and the patient will wear this. And I have a pretty much, I don't know, probably like 20% of my patients in orthosis still. So nobody, I mean, not everybody can afford to do, especially these days, all right? Yeah. And solution number two, what you're talking about, yes, we can be like a little bit more conservative, but as long as this position of the lower jaw in a zone of comfort for muscles. So if I can move, and pretty often we're doing this when for the aesthetic reasons. So if I can move the jaw a little bit back from the tense position, but it's still comfortable for the muscles, and I can check this and I can confirm this with electromyography. Yes, we can do this. We can do this.
That's good. Interesting. Because that's the same approach that Dr. Cyril Gaillard from France, neuromuscular doctor, he also, what he presents is how he's combining the COIS deprogrammer with electrical stimulation to be able to determine the vertical dimension exactly when they want to finish the case, and of course to try to contain the patient for eventually this anterior advancement that in many cases made more complex the restorative phase or the orthodontic phase.
And I think some patients. I think Konstantin is right. It all depends per patient and what the sensitivity is. I remember many years ago we used to call them the narrow goalpost or wide goalpost patients, and what is their area of comfort zone really. If they have a very narrow comfort zone, as long as I guess you don't restart symptoms on these patients, it should be okay. But if it's a narrow patient, and we're talking about, you have had those patients, I'm sure, Konstantin, that 0.5 millimeter of difference made all the difference in whether being symptomatic or not. Those are going to be difficult to.
We're talking about 20 microns. 20 microns. So that's sometimes I have a patient, everything beautiful, no symptoms. I touch the orthotic in one spot, just brush away a little bit of acrylic, and patient becomes symptomatic again. So that's happened.
Awesome.
Fantastic. All right.
Now it's all you, Javier.
I don't believe it. All right. All right, Konstantin, let's talk about the diagnostic records. Let's talk about what records do you take on that. Let's say you went beyond your consultation and the patient decided it's a go. Tell us about your diagnostic record.
Besides the X-ray and everything what we're doing on the first visit, then we're doing the polysomnography I already mentioned, and electromyography, computerized kinesiography, and sonography, like a standard package of diagnostic procedure for the K7 from with use of Myotronics equipment. And one part we always doing still doing casts, the models, and we calculating the models, and we mounting the models in an articulator and evaluate the pitch, yaw, and
are you using T-scan?
Yeah, but T-scan we're using as a screening tool. Actually, this is a part of the first appointment, just to show the patient that how the occlusion looks like, and then we're using T-scan all the time. Two things I'm using all the time: TENS and T-scan. It's like I don't know how to practice without these two things. And when the patients, when the doctors ask me, I just had this morning, I just had a webinar for doctors and for Russian doctors, and they ask me, what if I don't have it? What to do? So how I can treat? I mean, I don't know. I don't have an answer for this question anymore. So I don't know, because you know, if you see whatever you see on the T scan, you know that whatever the articulating paper will show you, unless you musician, it's not, it's false information.
Yeah, I think Ben Sutter mentioned that a retrospective study done in several universities is less than like 20% of the
12.5.
Yeah, it was a crazy number that is really not correct. So
yeah,
yeah, excellent.
Awesome.
Right,
do you know, by the way, that we're going to have Robert Kerstein talking to us tomorrow afternoon, because I couldn't get held in Domingo yet. So I think we're going to. So he's going to talk about physiology of the PDL and muscles. How amazing is that? That is going to confirm everything that we're talking about. And the beauty about that topic is, when I talk to Robert, I say, what do you think about these two? Can apply to any philosophy? You say, every single philosophy I use. This machine doesn't have no thinking about anything. Just under any condition you take a bite, you can just measure your forces. And I think that will make it a really good piece of equipment. Awesome. Hamid, I shut up, I promise.
I'll believe it when I see it.
Oh my God.
All right, we're gonna go jump into question number 5, because you kind of answered all the question number 4 already indirectly. Question number 5, whether you use an interdisciplinary approach, which you already mentioned that you're working with the osteopath and all the other specialties in your clinic. That's a beautiful setup. That's, I think, I would love to have that. I think it's every dentist set a dream.
Let me tell you that what we're dealing now with, we're not dealing with the dental problem right now. We treating patients with a medical problem, and sometimes we're using our dental approach to treat patients with medical issues. But we need to change. We need to use a medical approach, and this medical approach consists of many specialists, and that's why I have them in my Moscow office. And this is the reason why, because you can get together a bunch of experts, excellent doctors, excellent specialists, but if they're not on the same page, it's not going to serve to the patient. So everybody needs to be on the same page, understand the problem, and see the problem from the kind of same view. And this is what we try to establish, and we did in Moscow, and this is what I'm missing in Boston, actually.
Fantastic. Okay. Let's talk about a sequence for your treatment on a case, for instance, that's going to become second phase restorative. Tell us about your steps for analysis and establishment of the new vertical. How do you go about that?
Okay. The main thing, the vertical we establish according to the TENS, because the TENS is going to give us a physiological rest position. We're using some vertical indexes, Shimbachi and LVI, as a reference point, but mostly we establish the vertical according to the muscles. Then we confirm everything with facial aesthetics, and later with phonetics as well. And then this is what we establish when we're doing like a first phase. And then our protocol, like we transfer this to the wax up, and sometimes we're doing digital wax up, sometimes most of the times we're doing still regular wax up, and then we transfer everything to the final type of restorations. I don't know if I answer your
Yeah, no,
questions.
that's fine.
Yeah.
All right. So you did mention, touched on facial aesthetics. Um, where exactly are you? Let's say the patient comes to you with pain, but you already have the experience and you know that that mouth is broken down, and you see it in your mind that this is going to be a restorative case somewhere down the road after you stabilize this patient. When do you start thinking about aesthetics in your workflow? Is this a second thought later? The reason I ask you is that, you know, with Javier and I, we kind of like try to anticipate because, you know, like you mentioned, your vertical, you let the tens give you an insight. Where we've found is that sometimes that tens vertical is a little bit exaggerated, and we find that possibly maybe the joint is not quite in a tight pack. And then if you try to do something like that, you would have like really long restorative products at the end. Where do you start looking at these facial and really aesthetic concepts like incisal edge display or tissue display? When do you start?
Just because before you answer that, just because you mentioned Chimbasis,
Yeah.
and then Chimbasi, you know, is a CJ to CJ, and then is a lip and a face behind, and sometimes those numbers kind of throw you really out of the facial harmony.
All
So
right.
that's like the way we want the answer.
All right. So to answer your question, when I see the patient at the front desk, then I see and think about aesthetics. Okay. And I already gave example. When you try to determine the position of the jaw, and of course you take in consideration everything. And I mentioned about all these indexes as a starting point. It's not like you mechanically use all these numbers and determine the length of the teeth and et cetera, et cetera. No, this all thing helping you to see where the final size of the teeth, final smile, and everything what we try to create. But if the physiology require that the jaw supposed to be in like 1 millimeter forward, and you see that in the back because of very deep plane of spear or step behind the canines, very big, and that's why you have to do long teeth in the back, so be it, because patient feel much better in this position. He can breathe, he doesn't have headaches, etc. And when you establish the occlusion, when you register the occlusion, like on a case 7, so you take all this in consideration. You already know how big the teeth is supposed to be for this particular patient, and you see, okay, this is this position of the lower jaw not gonna work for this aesthetic what you already have in your mind. So you try to find another position as long as you in this zone of comfort. So
or on the trajectory, you can, in other words, you sometimes try to close the patient more on that same trajectory of function that you.
Yeah, of course. And you're not mechanically using these indexes because the patient can have a very elongated teeth or short teeth or whole jaw can kind of rotate it down. So you take in consideration all these signs.
Thank you. All right, we're going to get to the question about the growth factors and the jaw joint. Do you have any familiarity with the different growth factor systems there are there, like IPRF or LPRF and PRGF and things of that nature? And do you know anything about the effect they may have in the joint?
No, I'm not familiar with this, but if we're talking about growth, this is what we, especially for kids and teenagers.
Remodeling, probably.
Yeah, corticalization.
Probably remodeling. Yeah.
Especially what I see with the young people, when you put certain appliances in their mouth, in a like 3-4 months, you can see some changes in the joint on X-ray. So, and this is what we're hoping for, to grow and remodel the condyle back a little bit, because sometimes, and this is what people sometimes saying, that our head of the joint is too much forward, but it's too much forward. In a lot of cases, too much forward because it's some deformation of the condyle. So, and if you put in the jaw in the right position, decompress the joint, it is in a certain cases you can see that it's remodeled back. This is what I can see with my patients.
Very well. All right. Let's go to question number 9. And I'm guessing this is a yes on your part, because we're asking everybody if they do. First of all, if they do see postural changes, and in order to see that, they have to first take notice of them, of course. Is it an expected or unexpected event, and whether it's always positive or negative or both?
No, of course we see the posture. And posture is very important component in our treatment, and that's why we have an osteopath, we have a myofunctional therapist, and we have a kinesiotherapist who is doing some exercises with the patient. So three specialists working on the patient posture, and we see the changes. We see, for example, it's like patient with a forward head posture. As soon as you put the jaw in a more physiological position, it's much better. And this is what feedback I'm getting from my osteopath, much better results osteopath can get, and patient will have a better posture, and you see the head getting back, and shoulders and everything. And sometimes, especially with cranial bones, I see some changes that what I didn't expect. I don't know if it's positive or my osteopath tell me that's all positive, but sometimes I don't know. But I see all of a sudden that now ears on a like more level than before, right?
Wow.
After like 1 or 2 visits to osteopath. So this is what I see. And also we see some negative changes, like we put the jaw in the right position, we see the head in much better, we take an x-ray, and we see that airway is more constricted than it was before. So this is what
do you do in those cases?
So we try to find the position of the lower jaw, and we try to work with the osteopath. But lately, we're using the mRNA appliances a lot to treat this.
To develop the base of the skull. Awesome.
Because very often it's position of the upper jaw. It's like needs to be more forward.
Right. All right. This is the next question. Is more of a fictional question. All right. Do you think at any point we're going to have this type of teaching, getting out of these private settings like your center into the more traditional school teaching, these physiologic parameters that we're all looking at?
Yeah, this is a question about if I'm optimist or pessimist, right? So you know, my youngest son just was admitted to Boston University Dental School, and he's gonna start this year his journey.
Go be
And
you. Wanna be you, Grab.
you're right. And I just we had a conversation like a couple of days ago, and I told him, I don't know if I can say it. I told
Nobody's
him,
listening. Don't worry.
I told him because he familiar with everything what I'm doing. He very often working in my office, and he knows everything about what we're doing, ICMA and the research. And he actually helped me to do research, and we publish article together with him. But I told him, when you go to dental school, just please shut up and try to learn. Don't talk about neuromuscular dentistry there. They're not ready yet. I really hope that it will be one day that they all gonna go to like physiological approach. And we just me and Prabhu finished and Dr. Schwartzman, my partner, finished the Tufts mini residency sleep disorders. And unfortunately, they didn't mention any of the treatment modalities what we using also.
I just registered for that. I'm going to start in October.
Oh, good for you. It's good program. But
I know that they're famous for their not being part of this whole revolution that's happening. Yes, but there are a lot of science and a lot of
no, you're going to be in Boston, so please come visit.
Yeah, absolutely. I'm going to be coming back and forth for sure. I'll definitely look you up and stop by the office for sure.
Yeah.
All right, let's go to the last question, Konstantin. You're getting to the end. All right. Now, thinking about the dynamics and the movement or the whole mechanics of what's happening inside the joint. In your experience, what do you think are the sequence of events? Is this a rotation, translation, and beyond that? Once you establish your ideal position, what type of occlusal scheme are you looking for? Can you talk about the specifics of the occlusal interdigitation that you're looking for?
All right. Now, first of all, we believe and we know now because all this 3D technology exists that translation and rotation happen at the same time from the beginning of the opening of the mouth. So I saw Javier showed us his research or whatever it was when you see that for every single patient you can see how the head of the joint moves. So, and if we're talking about occlusion, what we establish in the end of our treatment, it's of course it needs to be like every principle what I already mentioned, that it's supposed to be central contacts, it's supposed to be no interferences during the chewing cycle or on a closure. It's supposed to be guidance, canine guidance. I believe in canine guidance. Sometimes it's impossible to establish canine guidance, but when it's possible, we always try to do this. And curve of Spee and Wilson and all these principles we try to establish when we're doing occlusion. And
in your sequence of closing, are all the teeth touching simultaneously, or are you looking for let's say posteriors first and then light anterior? Some clinicians had varying degree of emphasis on that contact.
We try to establish symmetrical contact on both sides. So
posterior.
You scan, posterior, and sometimes anterior contact doesn't doesn't bother me at all. And in my profile, for example, for Invisalign, I ask them to leave a quarter of millimeter of space between anterior teeth to prevent any super contacts, class first prematurities in the front. So, and the same way I'm doing when I'm doing the restorative work, trying not to create any heavy contact in the front.
Fantastic.
We have a few questions from the, let's see. So Dr. Ramin is asking, Konstantin, who do you use for PT in Boston? That is another doctor.
I have several actually chiropractors closer to my office in Boston, so I'm using them.
So I think, Ramin, you guys need to talk in the private line so you guys can share the contact. Then I have Dr. Sarati. When the second phase is done and the teeth are longer than ideal in the aesthetic zone, how stable are the restorations in a long term? Do you ever get fracture or chipping?
Chipping.
Okay. So again, we did the research. And we got the patients who we finished like 10 years prior to this visit, and we checked the relationship between the length of the teeth and the length of the crown, and sometimes it's 3 or 4 times longer than the this is what in closure.
You're talking about crown to root?
No, crown, the crown of the tooth, real tooth, and the artificial crown. So, and sometimes in the back we see this like huge discrepancy, like ratio like 1 to 3 or 4. So, and we checked, and 95% of the, I don't remember the percentage, patients were fine. Why? Because it's balanced occlusion. It's not the regular occlusion when people like brox and clench, and if we put this crown in this environment, probably it's not going to last. But when it's balanced, when you have a very low tone of the muscles, so this occlusion works fine. Yeah,
that's an incredible number to have. That's great.
Yeah.
Then somebody just say, sorry, Dr. Konstantin, what you told your son is not going to work. I told my son when he was in school, and he always opened his mouth. And when he finished the school, they allow him to make the final work in surface electromyography. So
okay,
that's this.
we will see. But for some reason, I feel that I don't know about BU. I graduated from Tufts, so I don't know. I don't want to like for him to have a hard time there. So it's difficult.
He's gonna get black marks, huh?
Yeah. All right.
Fantastic! It's so great to have you with us, Konstantin. We should do this more often. We're always seeing each other in the meetings, and don't get to talk as much. Yeah. Thank you so much for sharing this afternoon with us, and putting some of your experience and some of your wealth of knowledge, sharing that with us. Okay.
Thank you very much.
Thank you, Konstantin. I appreciate it. So guys, we finished one more day. We have one more day to go tomorrow. We're gonna wake up with an amazing, crazy guy, friend of mine from Spain, Gerardo Juarez, and he's gonna be talking about posturology, but also he's gonna be talking about the Slovichek theory, because we don't have no information, and
that's another school of occlusion.
Of occlusion, yes, the School of Vienna also is called. And that's why I think Konstantin mentioned it, because this is really popular and strong in Europe.
In Europe, right?
Yeah, I have the opportunity to go and share with many of them, the people that speak. And honestly, I don't know the basis. So when I talked to Gerardo, I didn't even know that Gerardo it was not trained in this. And then when somebody questioned me, why you didn't invite anything for anybody for Slovacek? Say, because I don't have any close friend that knows. And then my friend just came on and say, okay, I know about it. And so he's going to teach us a little bit about what is the principles. He's going to educate us. Honestly, I have no clue about the principles that they do. So that's
don't forget, we're going to be putting the new the marathon schedule. Yes.
Yes.
People are asking about that.
So the scheduled marathon, we extended like 35 minutes more than normal. And so we go in, because we're trying to make 5 minutes break between, and still we're not safe to don't have any technical problems. So we try to organize the schedule in the way that facilitate more for the international speakers. And then we have some of the lectures pre-record, so that's going to help me. I'm going to pre-record my own lecture, because to me it's going to be difficult to contain. I want to still show you what is the concept of biofunctional dynamic occlusion and the integration with neuromuscular. So I will record myself, so I'm going to be contained in time. So I respect the 30 minutes, and I will show some of the principles that we consider with your workflows every day. And then 1 p.m., I hope Domingo Martin give me an answer tomorrow. Otherwise, we will have the Dr. Robert Kirstein with us, talking about this fascinating world of neurophysiology in reference with the periodontal ligament, because he has many studies that he show how the proprioception in the anterior segment is totally different reaction than the posterior segment. And don't forget that he was one of the developers of T-scan for 30 years, and they actually developed about the timeless occlusion technique. So I think we are going to have a great day tomorrow, and then we're going to give it a break for 2 days. Like you guys can go to intensive care and figure it out how many vitamin B you will need, because our brain is going to explode, honestly. Konstantin, I invite you to watch some of the other lectures. Honestly, it's a lot of good physiologic material into there. And also we appreciate that you share with your friends. I think this is what we're creating here. It's an initial platform to start talking about occlusion. And the idea is to create some sort of interest worldwide. The people can open about it, always trying to focus on what we have in common. So we try to get away the friction, and we focus in the positive things in life. So thank you, everybody.